Thanks very much. And thank you again to Ross and colleagues, the Foundation, for inviting me over. I always enjoy coming over to New Zealand, even though I sometimes have to spend time with Ross. So I'm going to do a fairly wide-ranging view of the role of diversion in responding to drug-related harm in general, then a little bit of a focus on what's happening in relation to cannabis and diversion in Australia. So to start off, I'll make sure that this device is turned on. It is indeed. To start off, what is diversion? And whilst I assume that many of you in the room will have an understanding of what diversion is, just bear with me while I give a little bit of a description. And if I do tell you something that you already know, which is start raving bleedingly obvious, do forgive me. Caution, water on road during rain. So what is diversion? It's usually referring to diverting someone from the criminal system into the health system. And there are different ways in doing that. It might be after the detection of offence, before being charged, or it might be as part of after part of a sentence is completed. So there are different spots at which we might actually offer diversion from the criminal justice to the health system. And we also need to recognize that diverse models exist in different countries, and indeed within Australia, different models exist in different jurisdictions. So for example, in the United Kingdom, historically in the 1990s, we had three broad models: an information model where police might provide advice to people who were in custody, a proactive model where police might work very closely with drug workers who might even be located within the police services, and then the more commonly known incentive models, which are about coercing or helping people into treatment, as illustrated here. Supposedly, diversion is cost-effective and a humane alternative response to the criminal justice system. And that's the assumption that many of us make. But it's not always the case. In some countries, in fact, diversion into treatment, and I use that term very broadly and advisedly, is used as a punishment. Sometimes the consequence of diversion is more onerous than the criminal sanction. So if, for example, before the change to diversion, the consequence of possession of 5 grams of cannabis might be a slap round the ear from the officer who confiscated it and tossed it down the drain, and now you're offered a 3-day appointment at a treatment service, some might see that as a more onerous punishment than the actual criminal sanction itself. And then, of course, we've got to recognize that some people might not think that what we're offering is actually a better alternative than the criminal justice system. And here's an example from some of the Aboriginal communities in the Northern Territory, who, you know, it's working when people run away. And this was a reaction to some of the very onerous mandatory treatment requirements that were offered in the Northern Territory. So keep that in mind. People don't always see the world as we might see it. The rationale for diversion is that the most important reason to consider it is that not that coercion is particularly effective as a treatment, and I'll come back to that point later on, but in fact that treatment may do much better than the pretty dismal record that we have from imprisonment or other forms of punishment. There are some arguments, though, that should caution us. The WHO argues that it's only legally and ethically justified if the rights of individuals are protected and critically, if effective treatment is provided. And this is a critical point. Coercion is not treatment. Coercion is a means to get people to the door of treatment. So we need to ensure that in the implementation of coercion and diversion, we don't actually infringe on people's rights. The problem as well is that not always are the systems treated equally. So when the purse strings get tight, what can often happen is that the funding is resolved in favor of the custodial goals as opposed to in favor of providing quality treatment. And then, as I said, there's some subjective interpretation of what coercion is. Some service users think that non-legal pressure is coercion. My mum made me come can be as coercive for some people as the police officer or the judge made me come. And in fact, when you ask people who successfully move out of chaotic drug use what prompted that, it's rarely treatment or legal entanglement that is mentioned. It's things like health problems, family problems, relationship problems, and so on, that seem to drive people to make significant and enduring change. This research by Wild is really interesting. He found that 37% of self-referrals thought they were coerced, whereas 35% of court referrals didn't think they'd been coerced. So it reminds us that we need to be thoughtful about the eye of the beholder, and that there's a huge subjective interpretation of what coercion is. So, the other key point that I've already referred to is coercion is not a treatment. It's a means of getting a person to the door of treatment, and whether it's effective or not depends on what happens behind those doors of treatment. And we constantly need to remind ourselves of this. So if you invest a lot in developing legal systems that allow diversion and coercion, without investment in quality treatment, you're likely to have limited impact. So, does it work? Well, up until the end of 1990s, Wild, who's done a lot of this research in the US, found that a large amount of the literature is actually opinion or debates about the legal and ethical issues that might arise. There was very little evidence about what the impact was. Now, I'll come back to this point several times. Lack of evidence doesn't necessarily mean it doesn't work. It means there's a lack of evidence. Now, fortunately, the evidence is improving in a number of countries. And the evidence leads us to a conclusion that some of the programs do reduce drug use. Some of the programs do reduce relapse risk. Some of the programs reduce criminal behavior. And there's some argument that they can, but not always, depends how they're implemented, can reduce policing, court, and prison costs. We also need to remember that coercion isn't just used in relation to illicit drugs, and in fact, it is used, for example, in relation to driving under the influence or driving while impaired from alcohol, and to some good effect. But consistently, the evidence comes back to this point, which I've already emphasized, and that is, unless you've got quality systems of treatment, you're likely to have poor impact. If you only use diversion and coercion for people who are the most disadvantaged and disrupted, people who have coexisting mental health problems, who are homeless, who have unemployment, if they're the only people you refer through diversion to poorly equipped treatment services, you're likely to have poor outcome. So the other thing that we need to be mindful of is that diversion can have unintended adverse outcomes as well, and we always need to ask, what might they be? One of the things is that you can have net widening, so that people who might otherwise have stayed out of the criminal justice system end up in a coerced treatment system simply because it's there. And this was an example of what happened in South Australia when they had a coercion, for example, or a treatment alternative to criminal justice, to possession of small amounts of cannabis. The other thing that seems to happen, as we've already heard mentioned this morning, is that there is often an inequity of access. So, for example, in Western Australia, where we had a system, change of law at the beginning of the 2000s, and the offer of treatment as an alternative to a punishment of a fine or appearing before a court, what we found was that Indigenous people were simply disadvantaged by that system, partly because of factors to do with their Indigenous backgrounds, because of social and economic inequities, but often because of the sheer distances that were available for people to access treatment. So if you live in somewhere that's 250 kilometers from where a treatment service is, being offered a diversion to that treatment service as an alternative to a fine or appearing before a magistrate might not actually work out simply because of the distances involved. We also have, often we see that people who are referred to treatment who otherwise would not have ended up with a charge. So do you end up getting referred to treatment for 1 hour, 2 hours, 3 days, 1 week, 6 sessions over 10 weeks, when in fact if you'd appeared before the magistrate, you might have ended up with a behavior bond or a $50 fine. On the other hand, do we decide not to proceed because the offense wasn't serious enough when in fact that person may have benefited from treatment? The other thing that happened in Western Australia and a number of other jurisdictions was that we found that the treatment services became full of people who had been formally referred, and it became increasingly challenging for people who hadn't gone through the criminal justice system to actually access a treatment service. So all of these things become challenging for the system and can sometimes result in low adherence or poor completion or retention rates. Here's an illustration of what can happen in a formal review. This is a recent review of a system in New South Wales conducted and published in 2013. So the credit system is aimed at adult defendants who've committed a range of crimes, including drug-related crimes, and drug-related crimes represent a significant proportion of the people who are offered this system. Their needs are assessed, they can be referred to a variety of different treatment services, and as I said, it includes, but it's not restricted to drug-related harm. The main aim is to reduce reoffending, but the review by Donnelly and colleagues found that being referred to the credit program was no more effective than court in reducing reoffending rates. Now, you might sit back and say, well, that's contrary to what we thought. It's not having the impact that we thought it would. But the problem here is highlighted that there's such a variability in treatment services that we have to ask the question when we do these evaluations, is it the system that's not working, or does the sheer variability in the quality of treatment that's offered, the services that might well be poorly resourced, is that what the problem is? And I suspect a lot of the time that is the issue. But pulling together the evidence, what are the features of effective programs? Well, I've emphasized this several times. If you don't have quality treatment, why are you coercing people into that treatment? Can you match treatment to individual needs? So for example, if you've got a 25-year-old who's got some problems with alcohol, but they're not alcohol dependent, maybe referring them to Alcoholics Anonymous might not be the best treatment match. If they don't do particularly well in Alcoholics Anonymous, do we then blame them for not being motivated to change their behavior rather than saying maybe we match them to the wrong sort of treatment option? As well, simply coercing people to treatment is not sufficient unless we can find a connection between what the individual wants and what the treatment service might offer. So how do we, if you like, engage the voluntary interests of clients? And then the evidence tells us that we have to avoid overwhelming the treatment system with people who don't necessarily want to be there and maybe don't necessarily need to be there. If somebody's found with 5 grams of cannabis and isn't dependent on cannabis, hasn't got severe cannabis problems, and doesn't have other key issues, what is the value of referring them to a 6-week course of treatment at a treatment service? Do they necessarily need that sort of intervention? And finally, the evidence tells us, particularly emerging from the US, that careful monitoring and having graduated immediate response to breaches in conditions of diversion or coercion can have a significant impact as long as those consequences are immediate and graduated. So where does all that lead us? I think there are still questions that we have to ask in the research about how effective diversion is, particularly when people are diverted to effective treatment. For whom is it most effective and for whom is it not necessary or least effective? And how do we ensure that we provide quality treatment? And then we have to ask, what are the key elements of treatment? What sort of things can we leave out? What must we include? And all of those questions, I think, whilst answered to some extent, still need to be examined. So taking that then to, and I think the batteries are going in this, it's not working every time. Here's a brief history of diversion in Australia. Many people think that diversion actually formally started with the illicit drug diversion initiative that was started by John Howard and his government a number of years ago. But in fact, some people would argue that within Australia, police had discretion to charge or not, and many police did exercise that discretion, and in a way, that is a form of diversion. But essentially, whilst there were different versions around up until the 1990s, Howard's government, the funding that was provided, the coordination that was provided, saw a big increase in the range of options that were available. And this might be from police diversion to court diversion to drug courts. Initially, a lot of the focus was on cannabis, and then more recently, it expanded to a focus on other illicit drugs. There was less contention about the focus on cannabis, and I had an illustration of that when I was head of the government services in Western Australia. Having diversion for cannabis had some minor contention from some of the more conservative elements of the debate. When we shifted that to include possession of small amounts of other drugs, such as ecstasy, amphetamine, and so on, I spent 5 days on the front pages of the West Australian newspaper being lambasted for leading the government to going soft on drugs. It was a far more contentious issue. A key feature of Australian diversion is that the intent is to divert people into education and treatment as opposed to just diverting them out of the justice system. And the eligibility criteria exists to try and match people. By the way, it was at the head of the slide, but I should mention my indebtedness to Caitlin Hughes and to Alison Ridder for the substantial work that they've done in this area. So people might be eligible on the basis of the amount of the drug that they possess, whether or not they're dependent, how severe their problem is, their age, all of their previous offending record, whether another offense occurred at the time of the possession offense or the drug offense. So all of these things come into the decision making about whether or not somebody's eligible and what sort of program they might go into. So within Australia, as in many other countries, there's a whole range: pre-arrest, pre-trial, pre-sentence, post-sentence, pre-release. All of these options exist in various guises around Australia. There tends to be a stronger focus on the front end, and as I said, there's tended to be historically a stronger focus on cannabis. Until recently, it only focused on illicits, but in fact, alcohol is increasingly being included. As I said, the eligibility criteria are diverse, and all or some of these might be taken into consideration. So it does vary by jurisdiction. There are very different systems around Australia, and at different times. So for example, in Western Australia until a few years ago, we had a system of decriminalisation. It was still a prohibited substance, but if you were found in possession of small amounts of cannabis, you were eligible for an expiation. You got a fine, but if you attended a treatment service or made an arrangement to attend a treatment service within 28 days, that fine was expunged, or you could challenge it in court if you wished. That got changed, and now a caution is offered. In most of the jurisdictions, there's an upper limit on the number of times that you can be referred or cautioned. Generally what happens is, in some systems, the police might give you a warning and simple information. They might give you a telephone number. Of course, very few people actually follow up with a phone call after they're given the telephone number. It goes in the bin around the corner or becomes a roach for the next joint. But nevertheless, it's an option that's provided. In other jurisdictions, you're referred to face-to-face interventions. And again, as I said, take-up rate seems to be influenced by Aboriginality, proximity, the ability to get to a service. Some jurisdictions arrest people, then discontinue the service. So you can see, you can't say what's the system in Australia. There are many, many different systems. Usually people under the age of 18 are excluded because they're referred to the juvenile justice system. The rationale for that is that, for example, as David has mentioned, the particular risks of juveniles who are using cannabis suggests that they shouldn't be able to expunge it by paying a simple fine, that you would want to assess and, where appropriate, refer them into treatment. So is it effective? Well, there's a strong argument that it's a better option than criminalizing consumers. There's also, unfortunately, limited evidence base, particularly in relation to cannabis use. Again, I want to stress, this doesn't mean it doesn't work, it just means that the research is not particularly sophisticated. There are concerns about the impact of coercion on treatment services. Does it distort the client base? Some systems of care have very poor take-up rates. For example, in Western Australia, despite many of us investing an enormous amount in trying to get the system through, and it was politically challenging at the time, the take-up rate was pretty modest. And so what happened was lots of people went without, they didn't go to treatment, they didn't pay their fines. So then what happened was the fine enforcement system actually removed their driving license, which meant that then they were driving without a license, which meant that they came in front of the court system. So with the best intentions, we ended up not necessarily having a system that worked as well as we'd hoped. The other thing that can happen is the anticipated savings are not always realized. One of the things we did in Western Australia is we did a calculation of what it would cost for a police officer to charge someone, to take them down to the station, to put them through the court system, versus referring them to a simple information education session assessment for future treatment needs. And it was very clear that that system of treatment education was much cheaper. But what happened was we had a Royal Commission in Western Australia which actually, in relation to policing, and because of anxieties about corruption, even in the new system, people would take people down to the police station, weigh and measure the cannabis that they had, carefully record it because there was anxieties about corruption or claims of corruption and compliance with the requirements of the Royal Commission, which meant that some of the anticipated savings weren't necessarily realized. And the other problem I think we need to be mindful of, and this has been mentioned again in the last couple of days, we have a system in relation to cannabis which focuses on a very small proportion of people who consume cannabis. Only 3 to 4% of people who consume cannabis in Australia actually come to the attention of police. But we have a system that's largely geared around those people who come into the court and police system. Now, clearly, we need an adequate response for those people, but what about the 96, 97% of other consumers? From a public health perspective, what are we actually doing? And I'll talk more about that this afternoon. The other thing is the ridiculous nature of some of the systems. Most systems say you're only allowed one caution or one referral or one expiation notice. First things first, majority of people who come to the attention of police for cannabis-related offences in Australia don't come to the attention of police again. That doesn't necessarily mean they're not doing it anymore. It just means that they don't get caught again. We were talking about 8%, 9% in WA. But the people who come to the attention of police more often and the court system are probably more in need of treatment services than those who don't. So political decisions determine that you're only allowed one caution, one referral to treatment. But I would suggest that perhaps need would dictate that those who are more commonly coming to the attention of law enforcement services for cannabis-related problems are probably the people most in need of options to go into treatment services. So going back, what are some of our future thoughts on this? We shouldn't rely excessively on legal mandates to enforce treatment adherence. There is a role for coercion, there's a role for diversion, but we shouldn't excessively rely on it. And it's no good just telling people to change or else. The teeth of the law will bite them on the behind. We actually, to make a difference, we must invest in quality treatment. Without quality treatment, we're setting people up to fail. And threat without quality treatment simply breeds reactance and negative affective states. So you know it's working if people are running away. That's not the sort of treatment system that we actually require. And finally, at the end of the day, if we don't improve the quality of people's lives, if people are affected by poor economic, poor recreational, poor cultural connection, poor connection to school, if we don't invest in building quality outcomes, then it's likely that miserable abstinence is not likely to be sustained. And so there is life after substance abuse. It's not particularly fun. Unless we make it fun, we're going to have limited impact. Thanks very much.